20%, or the most liberal criterion of just 1%, the hazard ratio goes up rather, and so the results are basically attenuated, weakened with each more inclusive view. And essentially this is like Russian nesting dolls, where what this really suggests is that all the real benefit is still in that high PD-L1 group, and you dilute that effect with the broader population. You just don't dilute it enough to totally negate the benefit. But the big issue is, how do you do if you're in that group that wasn't already established as a standard of care in the 1 to 49%. This is an exploratory analysis, and it shows that the patients who got pembrolizumab did not do better. Now, you could say, well, this still means that you can do just as well. It has generally a more favorable tolerability than chemotherapy, so we should still think about or tend to use this first line. But I would say that because there was no crossover, this was really substandard care for the patients who were assigned chemotherapy. At that time, we knew that immunotherapy had a very clear survival benefit as a second-line treatment, and these patients did not get access to it. So you have one group that got access to chemo and immunotherapy, one that only got chemo, and the pembro arm only did as well as a hobbled standard of care. So I would say that in truth, it is not a compelling option. But what is really another important issue is that there is an alternative approach that looks way, way better. Specifically, this is ushered in by KEYNOTE-189, another important trial that was presented in the spring of 2018. And this was chemo backbone plus or minus pembrolizumab. The chemo in this setting was cisplatin or carboplatin with pemetrexed. It was a 2-to-1 randomization to the chemo arm over placebo with that. These are patients with non-squamous, non-small cell lung cancer, could not have an EGFR mutation or ALK rearrangement, and allowed patients across the entire spectrum from negative PD-L1 to low to high. And patients who were not progressing after 4 cycles could go on to maintenance pemetrexed with either placebo or pembrolizumab. And this trial was screamingly positive with a survival benefit. You see here a hazard ratio of 0.49. We don't get to see enough of these kind of Kaplan-Meier curves, especially for an overall survival difference. And what was also very impressive is that the benefit was not just limited to those patients with high PD-L1 who we already knew benefit from immunotherapy. Yes, those patients on the far right got a very impressive benefit with a 1-year overall survival of 73% for a disease that previously 10 years ago was closer to 30 or 40%. But you also see a major benefit in the patients in 1 to 49%, as shown in the middle, or even those with negative PD-L1 and less than 1%. So that approximately 35 to 40% still had a hazard ratio of 0.59, so showing that all of these patients benefit from this approach. And for the patients with positive PD-L1, or certainly those with high PD-L1, this is a competing standard of care option along with single agent. Now there are other, oh no, this is like, damn it, it's not meant as a joke, I swear. So as a reminder, turn off your cell phones. So what? So what I was going to say was there were other trials that have looked at chemo and immunotherapy, and this is one of them. Empower 150 looked at atezolizumab integrated with a chemotherapy backbone, in this case also with bevacizumab. So the bottom arm of carbopaclitaxel bev is a standard of care for non-squamous, non-small cell, one of the options. And the primary investigational arm is shown in the middle in blue, adding atezolizumab to carbopaclitaxel and Bev, and then with a maintenance phase of atezolizumab and Bev. And this was a very large study, 1,200 patients, all with non-squamous, non-small cell. And unlike other trials of in this setting, this allowed patients with EGFR mutations or ALK rearrangements, but it was intended for those who had received and progressed on or couldn't tolerate a targeted therapy. So it was not meant to be a first-line therapy for those patients. There was also a third arm that was a kind of secondary investigational one that omitted the Bev and replaced it with Tetezo instead of adding. And these are the results. You could see progression-free survival is statistically significant and impressive separation of the curves with a hazard ratio of 0.59. Overall survival also significantly improved with a hazard ratio of 0.76. So an option, but this is one that now we have a different chemo regimen of carbo, pemetrexed, pembrolizumab without a 4-drug regimen, no bevacizumab, no taxane, which many of us are disinclined to give. And so it's an option. It's actually FDA approved, but it's not one that typically bubbles up as a top choice. It is one that might be considered for patients with an EGFR mutation or an ALK rearrangement after they've progressed, but the FDA actually has not approved it for that population. These patients did seem to benefit comparably to the other patients in the trial. Another study is Empower 130. This is another atezolizumab plus chemo trial. This is also for non-squamous, non-small cell, but it gave a different chemo backbone of carbo and nab-paclitaxel, which is not one that we typically use for non-squamous, non-small cell. But the idea was this is one that actually doesn't require steroids, and there has been some concern about steroids negatively interacting with giving immunotherapy. And this did allow patients also with an EGFR mutation or ALK rearrangement. But unlike the preceding trial, the patients with an EGFR or ALK rearrangement did not seem to benefit. The trial was overall positive for progression-free survival and overall survival benefit. And actually, the EMA, the European regulatory agency, just approved this for patients with non-squamous, non-small cell. And it may become available in the U.S. too. But again, the competition nowadays is not chemo alone, but a chemoimmunotherapy regimen we already have. And that is a higher bar that I would say this doesn't necessarily exceed. And then finally, another one, Empower 132, carbo or cisplatin with pemetrexed and atezo. So this is remarkably like the one I showed several slides earlier with pembrolizumab, Keynote 189, that became the standard. This one was for non-squamous. Progression-free survival is benefit, but is significantly beneficial. Overall survival does not meet statistical significance, and so this one is not one that would be particularly favored. So, but there's a range, and we're going to see more of these trials. It's just going to be a question of how many could we possibly use if we have one that works well, is well tolerated, et cetera. Now, let's turn to the squamous setting where there's a similar trial to Keynote 189. This was presented also at ASCO last year and subsequently published in the New England Journal. Keynote 407, different chemo backbone, carboplatin with paclitaxel or nab-paclitaxel, and gave either placebo or pembrolizumab. This is a 1-to-1 randomization, and the primary endpoint was progression-free survival. That was very significantly superior, hazard ratio of 0.56. Overall survival also impressively improved with the addition of pembrolizumab, and this was actually presented at the same meeting at the same day as Keynote 042, and I think rightfully eclipsed those results as an appealing option because this was a study that looked just as good for the patients who were in the 1 to 49 range, or even less than 1%. You can see on this forest plot that those subgroups had hazard ratios that were absolutely in line even with those patients who had high PD-L1. So chemoimmunotherapy is just a more compelling approach in these studies, particularly for those patients who are less than 50%. And as you can see, just about every way you slice it, these subgroups all come out benefiting from the addition of pembrolizumab, regardless of which taxane, et cetera. There was another study presented at the same meeting with atezolizumab, very similar, carbo-nab-paclitaxel as the standard chemo, and the primary comparator being carbo-nab-paclitaxel and atezo. The top bar of carbo-paclitaxel with atezo was a kind of conditional secondary investigational arm. This was about 1,000 patients with advanced squamous, and it showed that there was a significant improvement in progression-free survival, but no improvement thus far in overall survival. And it's never going to look as good as Keynote 407. So I think this is going to emerge as a somewhat historical footnote. Let's turn to the setting of stage 3 non-small cell, which is one where we were banging our heads against a wall, frankly, for more than a decade without any improvements until immunotherapy came along. And it's specifically this trial as the first that changed our standard for the first time in decades. This PACIFIC trial uses durvalumab, and it looked at its role in the consolidation setting after concurrent chemoradiation for unresectable stage 3 disease. This was another 2-to-1 randomization to active drug versus placebo. All of these patients had unresectable stage 3 disease, squamous or non-squamous, and received at least 2 cycles of chemotherapy and concurrent chest radiation, as is the standard. And then, if they hadn't progressed and didn't have a decline in performance status, went on to a year of either durvalumab or placebo in that time. And this demonstrated a significant improvement in progression-free survival as well as response rate. And that was the first information we had back in the fall of 2017. Frankly, these results were so impressive for progression-free survival, which was the primary endpoint of the study, that the FDA approved it a few months later, and it really became the standard of care. But we didn't have overall survival until about a year from that initial publication and presentation in the New England Journal. This was one that actually got 2 New England Journal publications. And this one is showing that you have a sustained survival benefit. The curves separate early and maintain that separation for 2 years and ongoing. So it's not like once the drug stops, the curves immediately start to converge again. It's not clear whether we're truly curing more of these patients years and years later, but this is as good as we could hope to get, I think, years out, and suggests that they aren't converging right away after we stop the drug. Now, there are some subgroups that we are debating about whether to include durvalumab and recommend it with enthusiasm. Most subgroups really seem to benefit regardless of smoking status, age, sex, squamous or non-squamous. The main questions are around EGFR status. You could see toward the bottom that those with positive EGFR mutations don't seem to necessarily get the same kind of benefit. And we'd seen this trend in advanced disease as well, that the patients with EGFR ALK seem to be among the least benefiting from these drugs. So it is a question. And another one is whether the patients with negative PD-L1 should get this, because you could see that at the bottom of this forest plot, the patients with PD-L1 less than 1% don't seem to get an overall survival benefit. But this was an unplanned post hoc analysis, and there's limited patients who were part of this study, this particular analysis. So many of us generally recommend this with the thought that these were patients included in the trial and the trial was extremely positive, and we don't have clear evidence to exclude patients from that benefit. Finally, let's turn to small cell, which kind of like stage 3 has been a tough nut to crack with standards that we've gone back to for decades without much change. And this was a huge change last year when we saw that there was a benefit from adding atezolizumab to standard chemotherapy for extensive stage small cell. This is regardless of regardless of PD-L1 expression, which is not commonly expressed to high degrees in small cell. The standard chemo was carbo and etoposide with either then placebo or atezolizumab, and then maintenance with atezo if they were assigned to that arm. And this trial demonstrated a statistically significant but relatively modest improvement in progression-free survival, but a more compelling improvement in overall survival. Now, the median overall survival difference is just a couple of months, but the curves separate out more significantly toward the right side, so there are clearly patients who are significant beneficiaries of this. We haven't identified which patients those are, but this has now gotten an FDA approval and is a new standard of care that I would argue with a hazard ratio of 0.7 represents a meaningful, gratifying improvement after spending a lot of time trying to find anything that would move the needle. So in conclusion, immunotherapy has now become integrated as a standard of care in stage 4 non-small cell lung cancer. It started out in the second-line setting, but then moved to first line, being studied and showing its benefit in the high PD-L1 expression group, for which we have pembro monotherapy. We've actually, just in the last week, gotten some new data, just long-term results 3 years out with the KEYNOTE-024 trial that shows that patients who stopped after 2 years as per the protocol, most of them continued to do well even off the drug and are now 3 years and ongoing. So amazing, and helping us ask questions of what might be possible that we couldn't have imagined before this, and is it possible for patients to live years and years and die of something else after being diagnosed with stage 4 lung cancer. Now, chemo and immunotherapy is also an option for these patients, and it's frankly debatable. Many of us would individualize based on the tumor burden of the patient, the pace of their disease, etc. For PD-L1 low patients in the 1 to 49% group, chemoimmunotherapy, I would argue, is the clearly best choice. We have KEYNOTE-189 for the non-squames and some alternatives that could be considered. And in the setting of squamous non-small cell, KEYNOTE-407 with carbo and taxane plus pembro is the pace setter here. Now, these patients are technically eligible for pembrolizumab monotherapy, but I would consider that to be a less strong choice, particularly when we are worried about patients declining and having attrition from first line to second. If they decline, they may never be candidates for anything else after that. So we generally prefer to give stronger treatments up front, not sure if we're ever going to get another shot on goal. So in the stage, in the patients with less than 1% PD-L1, chemoimmunotherapy with the regimens I mentioned is really the clear standard, and monotherapy is not a strong choice. And then in the setting of stage 3 unresectable and extensive stage disease, settings where we wondered, will we ever be able to change the prevailing standard of care, we found that immunotherapy can do that. Durvalumab consolidation has shown a meaningful survival benefit. We'll need to see how sustained that is, but it is a new standard of care for patients who are eligible for it. And in extensive stage small cell lung cancer, the combination of carbo-etoposide and atezolizumab followed by atezo maintenance is a new standard of care. I should also mention that we just got results of a trial called Caspian that looked at cis or carbo with etoposide and durvalumab in extensive stage small cell first line. Very similar design and very similar results, frankly. Now, that one's not FDA approved, and with results so similar to what we saw in the trial called Empower 133, which has the design I show you, it's not clear that there's a reason to pursue that over what we already have. But it's great to get reproducible, positive results in a setting where a few years ago it was very, very elusive to ever see positive trials like this. So thank you very much. We will continue by going back to that vote. And this is the same question you saw before. In which setting is PD-L1 testing most clearly indicated for shaping clinical decisions? 1, extensive stage, small cell, then stage 3, unresectable, stage 4, non-squamous, non-small cell, 4, stage 4, squamous, non-small cell, 5, stage 4, non-small cell, either squamous or non-squamous, all of the above, or uncertain. We've graduated to music. Great. Music to vote by. Okay. Okay, so some work to do with this. I would say that the best answer is really the stage 4, regardless of histology. I would say that there is not a clear value in doing really for PD-L1 in extensive stage small cell or unresectable non-small cell. So I would consider the best answer to be option 5 there. And we'll move on to Dr. Sanjay Mukhopadhyay, who's going to be talking about the how.
Thank you very much, Jack.
Sure.
Thank you for having me at this conference. Thank you all for coming and for sharing your afternoon with us. Thank you very much, Sandeep, for joining our illustrious group here. I'm very honored to share the stage with both of you. We are going to actually turn it back now to pathology and to the nuts and bolts of what this means. So we've already made a compelling case for testing PD-L1 in our non-small cell cancer cases, and I'm going to show you what that means in practice. All right, so I have no relevant conflict of interest to report. And we will, like the previous speaker, Dr. West, we are going to start with a quick survey of the baseline here. So the question that we have now is, when evaluating PD-L1 immunohistochemistry in non-small cell lung cancer, so PD-L1 in non-small cell lung cancer, which of the following is considered positive? All right, so which of the following is positive? Is it membrane staining in tumor cells only? Is it any staining, cytoplasmic or membrane, in tumor cells? Is it staining in tumor cells and inflammatory cells? Is it any staining but only in inflammatory cells? Or is it cytoplasmic staining but in inflammatory cells only? Or is it unclear? So you've got 6 options. We're going to move on to the next slide. 139 responses already.
Wow.
42 out of 139 possible. All right, so we have a broad spread here. And we're going to try and, so the point of my talk is to try and narrow this down to the right answer. And in fact, most of you have got the right answer here. But we're going to try and make it extremely clear at the end of this talk what constitutes positive staining for PD-L1 in a non-small cell lung carcinoma. So I'm going to talk a little bit about testing platforms and why there's so much confusion, and try to limit that confusion, make it very simple. I'm going to show you how I interpret PD-L1 immunohistochemistry in non-small cell. In fact, I have a free video that you can watch on YouTube which has illustrations of PD-L1 positivity. It's very short, so it's very easy to follow, and it's free. And I'm going to talk about today what makes a good sample for PD-L1 immunohistochemistry in non-small cell carcinoma. What should you be asking your clinicians for? And finally, best practices for biomarker testing. So let us start with testing platforms. This is what actually creates the most confusion, but I'm going to try and simplify the issue so that it is relatively easy to understand. Now, the problem with current PD-L1 testing, and it really is a problem, is that all these multiple trials have created multiple platforms, multiple clones, multiple diagnostic types, and multiple scoring systems. So it's not at all as easy as just saying positive or negative. But what I'm going to try and do is focus it down to the 22C3 antibody clone, which is what we use in my institution for lung cancer therapy. And the trial that Dr. West showed, the REC trial, the first one that he showed, actually used the 22C3 antibody, which is on a DACO platform, and is used to give the drug pembrolizumab. It is a companion diagnostic, and it's actually pretty simple for the pathologists in the audience. The difference between a companion diagnostic and a complementary diagnostic is a companion diagnostic, you have to have the test to give the therapy. You have to have the test. It's mandated. A simple thing that you could understand is HER2, for example, in breast cancer. You have to have the HER2 test so that the drug is given. Similarly, you have to have PD-L1 immunohistochemistry to give pembrolizumab. A complementary diagnostic, on the other hand, is recommended but not necessarily mandated. So you don't necessarily have to do it. It becomes optional. So for the 22C3, there are two categories that are considered positive, and that also makes it slightly difficult. But the simplified explanation is this. For first-line therapy, you want at least 50% of the cells to be positive. At least 50%. That's for first-line therapy. If the patient is being treated in second line, you need 1% becomes the cutoff. And 1% means essentially that the only people who are considered negative are those who are completely negative, so no tumor cell stain. If there's even one tumor cell that stains, that becomes eligible. So really the bar is very low to call something positive in that setting. Now the other antibodies, SP263, 142, 288, those are used in different settings, but I'm not going to get into it here because that just will add confusion. So we're going to talk about 22C3 and in the setting of non-small cell lung carcinoma. Now, people have tried to, so after the horse actually left the barn and all these studies were done and everything, descended into chaos, pathologists tried to rein it in and say, hey, listen, can we reconcile all this? Do these antibodies perform in an equivalent manner? So there are many studies that came out subsequently trying to see whether, for example, 22C3 is equivalent to SP263, whether SP263 is equivalent to 142. And I'm just showing you one example here from Gall et al. Dr. David Rim was on this, JAMA Oncology. And what they did is they looked at the more common antibodies. So they looked at SP142, E1L3N, 9A11, SP263, 22C3, which we'll be talking about today, and 288. And essentially, to boil down the results, they were all, roughly speaking, equivalent. Now, that means that if you use some sort of a reference standard, in this case they use quantitative immunofluorescence, that all the antibodies essentially stained the same percentage of cases, even though there were some minor discordances. And then other studies have looked at the same thing. So I've listed some of the common ones. The Blueprint phase 1 and 2 are especially good, well-conducted studies. And again, they looked at the same PD-L1 assays. I would direct your attention to the staining results over here that are indicated in the red box. And by and large, if you want to take a take-home message from all these harmonization studies, essentially all the antibodies perform similarly. The one outlier, consistent outlier, seems to be SP142. So SP142 has performed in the sense that it is less sensitive than the other antibodies. So if you look, again, if you consider one reference standard and say 22C3 stains 80% of that, SP263 stains 80%, E1L3N stains 80%. Generally, SP142 will be less sensitive and stain a lower percentage of those cases. Now, does that mean that the antibody is invalid? I don't think it means that, because its clinical validity has already been tested in the clinical realm. But what it does mean is that these antibodies are probably looking at different things. So there's something different about the SP142 antibody than the other ones. And so I think that is the take-home message, that there is basically one outlier, but the other antibody clones are essentially equivalent. Now, how do you interpret PD-1 immunohistochemistry in non-small cell cancer? In my institution, we test all non-small cell cancers regardless of histology, once we consider that they are lung primaries, they are all tested reflexly. We don't wait for our clinicians to order them. So the moment I start looking at a biopsy and I think, hey, this is going down the non-small cell pathway, I'm already thinking of getting the PD-L1 testing done. So, and I'm already thinking, so this is squamous, I'll have to do PD-L1 alone. This is not squamous, I'll have to do the molecular testing and PD-L1. So the life of a lung cancer pathologist has changed in that sense. A few years ago, you didn't have to do that thing. You'd have to think of, what is this tumor? Is it adenosquamous small cell? Then you'd have to think of, where is it coming from? Is it lung or not lung? And that was the end of it. At some point, you didn't even have to do adeno or squamous. You could just leave it at non-small cell. But now, not only do you have to do subtyping, you have to do where is it coming from, and then you have to do what testing do I have to do down the line. So everything needs to come together. All right, so I'm going to extremely simplify what needs to be considered. So here is the point that's most relevant to our initial question. Only membrane staining is positive when it comes to PD-L1 immunohistochemistry. Only membrane staining. So if it's cytoplasmic alone, it doesn't count. Nuclear doesn't count. It has to be membrane staining. If it's both cytoplasmic and membrane, the membrane counts, but it has to be membrane. Is that clear to everybody? So tumor cells and only membrane staining. So here's an example of what a non-small cell carcinoma looks like on the left side. And on the right-hand side, you have a clearly positive membrane PD-L1 staining of non-small cell carcinomas. Now, the good news is that all the harmonization studies, when you have a clear-cut positive case like this, 100% of tumor, all of them perform the same. All the antibodies perform the same. The problems occur at the very low end of interpretation, 0 versus 1%. I mean, everybody in this audience who interprets immunohistochemistry knows that that is a very, very tricky thing to do. Whether somebody is completely negative or maybe one cell is positive, that's a very tough call to make. And if you as a pathologist are saying, hey, this patient might be denied therapy if I call them 0, you might say, well, maybe I'll call it 1 instead of 0. And so I've seen in practice people actually do that. They don't want to have the burden of a 0 fall on their shoulders. But this kind of stain, 100%, is very, very reproducible among clones and among pathologists. The second take-home message is that in non-small cell carcinoma, our job is very simple compared to GU or GE junction or other sites. We don't need to count inflammatory cells. So it's only tumor cells that makes our job very simple. So in non-small cell cancer, count only tumor cells, ignore the inflammatory cells. So in this case, all you have to make sure is that the cells that you're counting are actually tumor cells, and that for that you do need some morphologic skill. You need to be able to tell that the nuclei in these tumor cells are those nuclei in these cells are malignant nuclei, and so it does take some skill in interpretation. The third thing is, and this is what complicates interpretation, is that macrophages are typically positive for PD-L1. The staining tends to be a little bit more dim, but there is membrane staining for PD-L1 in normal alveolar macrophages. So if you just blindly and quickly look at something, you might, this is sort of a pitfall in staining. So this is an example of macrophages on the left-hand side, just normal alveolar macrophages, and this is an example of the PD-L1 staining that you get. So if there is one pitfall that you really need to remember in PD-L1 interpretation, it's this, is do not interpret these cells as positive because you only should be counting tumor cells. And this is how things can get complicated. So in this picture, on the left-hand side, you see there's tumor cells towards the upper left where the big arrow is showing you tumor. Cells at the bottom right are macrophages. So those cells should not be counted, and only the strong staining cells at the top left should be counted as positive. Things can get complicated if the macrophages are actually mixed in with the tumor cells, and then it gets a little tricky to tell what's tumor and what's not. So here's an example of that kind of complicated situation. So here is a non-small cell carcinoma. It actually has some macrophages within it. So if you look at that little arrow there, it shows you a little cluster of macrophages. So if you were trying to decide, is this a completely negative tumor? Is this 0%? Or is this, 1%, 2%, 5%? You might look at that cluster and say, hey, I'm going to give this a, 6%. But that would be wrong because these are not tumor cells. These are macrophages. So you should subtract that, completely ignore that, and look at the tumor cells alone. And as you look at tumor cells, you will not find any convincing membrane staining in any cell. So this is a 0%. It's a negative PD-L1 test. Another way in which they've simplified the scoring is that intensity doesn't matter. So this is different from HER2, where you have to consider how strong the staining is. In PD-L1 immunohistochemistry, it does not matter. So any intensity of membrane staining is positive. So for example, the picture on the left-hand side is positive, but the picture on the right-hand side is also positive. It doesn't matter. So even the weakest of weak membrane staining is positive in lung cancer. Staining intensity varies within the same tumor. This is one of the biggest problems in small biopsy interpretation of non-small cell carcinoma staining, is that within the same non-small cell carcinoma, like here and there, you can clearly see that some areas are moderately positive, but still positive. Some areas are strongly positive, still positive, and yet other areas in the tumor could be completely negative. So there is heterogeneity, especially when you see resected tumors. It's clear that there's heterogeneity in staining PD-L1. So theoretically, if you put a needle in the tumor, you could go into the negative portion and be completely misinterpreting the complete PD-L1 positive. So this is something that is, it's just impossible to account for this, because in some patients you will only have small biopsy samples. You cannot completely account for tumor heterogeneity, and some degree of inaccuracy will persist. And that's unavoidable, because small biopsy specimens, as you know, are the only specimen in about 70% of lung cancer patients. So this is an unavoidable problem in interpretation of PD-L1 immunohistochemistry. Finally, the report should report the percentage of tumor cells that are positive. There's no positive, negative report. You have to give how many % of cases are positive. And the way we do that is we just simply report tumor cells positive, 100% tumor cells positive, 1%. You will see this thing called the TPS, or the tumor proportion score. That's just a fancy way of saying what % of tumor cells are positive. That's what the TPS means. It's a very, very simple thing. The other one, which is the CPS, is a much more complicated thing, but that doesn't apply to lung cancer, so I'm not going to go into it. The TPS is what applies here, and it's a very simple interpretation. What is a good sample for PD-L1 immunohistochemistry? Routine formalin-fixed paraffin-embedded samples are all great. You must have at least 100 cells. If you have less than 100, that is inadequate. And formalin-fixed anything is good. Cytology, it's increasingly emerging that cytology can be used for PD-L1 staining, but you must validate, because there is some degree of discrepancy between cytology and histopathology specimens. This was very well shown in a paper by Sinchita Rao Chaudhary. The first author was Knoll. In that, they not only stained cell blocks, they also stained cytology smears, and there was a very high degree of concordance between cytology and histology, with only a few discordances. Best practices for biomarker testing: all patients should get immunohistochemistry, and you should look at only PD-L1 tumor expression, and we use the 22C3 antibody. All patients with adenocarcinoma should get not only PD-L1, but also molecular testing for the routine markers, EGFR, ALK, etc. Broad multiplex panels are better for various reasons, which we cannot go into now. And completion of molecular testing is recommended within 10 to 14 working days. Of course, that's not the focus. The focus of this talk is PD-L1, and PD-L1 generally takes only, is a same day test or next day test, especially if you're doing it in-house. So it's very, very quick turnaround time. Before I end, I would warn everybody here, with the advent of molecular testing and PD-L1, one big thing has happened is you cannot waste tumor tissue on immunohistochemistry. So you must limit your immunohistochemical panels. For some of my tumor cases, I don't do any immunohistochemistry at all. And when immunohistochemistry is used for subtyping, I use very judicious panels. TTF1P40 is generally sufficient. So to conclude, there are 4 approved PD-L1 immunohistochemistry assays on 2 different immunohistochemical platforms with different scoring systems. But the one to remember is 22C3, which is used for pembrolizumab and is the sole agent that requires PD-L1 positivity as a part of its indication. I'll stress again, PD-L1 positivity is membrane staining only and in tumor cells only, reported as a percentage of the total cells. Beware of macrophages, don't count them. And when interpreting a biopsy, especially in the modern era, don't waste tumor tissue on immunohistochemistry if you can help it. Thank you for your attention. So I'm going to go back to the initial question, and let's see if we have improved our performance now. So let's vote. when evaluating PD-L1 immunohistochemistry, which of the following is considered positive? Membrane staining in tumor cells, any staining in tumor cells, staining in tumor and inflammatory cells, any staining in inflammatory cells, cytoplasmic staining, or uncertain. All right, we did great. Thank you very much for your attention.
Excellent.
Welcome, Sandeep. Sorry I went over.
Great, and so to tie it all together and bring this home, I'm going to talk about predictive biomarkers for cancer immunotherapy with an eye towards the future and upcoming biomarkers. These are my disclosures. And so quick survey. I think it skipped over the question.
We get the survey question.
There we go. Which of the following biomarkers should not be routinely tested for in a patient with metastatic non-squamous non-small cell lung cancer and limited biopsy tissue? 1 ALK, 2 BRAF, 3 GFR, 4 microsatellite instability or deficiency in mismatch repair, 5 NTRK fusions, 6 PDL1, 7 ROS1, or 8 uncertain. Great. So you guys got this right. Microsatellite instability, 41%, should not be part of the routine testing workflow, especially with limited biopsies. Save that testing for gynecologic and GI tumors. And so I'm going to talk a bit about the background of immunobiology, which will explain what the biomarkers that we're actually assessing on in patients, followed by tumor mutational burden, which is an upcoming biomarker, microsatellite instability, which this group has an excellent grasp of, as well as some potential new biomarkers. And then finally, is PD-L1 testing enough for immunobiology in 2019 for the care of a patient with metastatic non-small cell lung cancer? And so fundamentally, there are a variety of immunologic synapses. Immune cells traffic from the bone marrow niche into the tumor microenvironment. They interact with tumor-draining lymph nodes. And so when we get a biopsy on a metastatic patient, we're looking at the immunologic synapse between the tumor cell and the cytotoxic T lymphocyte. That's where we find PD-L1 staining. But I'd be remiss to mention that these T cells actually encounter multiple other cells on their journey into the tumor that can activate these T cells. And in fact, you can have PD-L1 expression in the tumor-draining lymph node between the cytotoxic T lymphocyte and the dendritic cell, for example. And this is an area that in a metastatic patient, you may not have that specimen. In an adjuvant sample, you may. And so the idea that there may be patients who are PD-L1 negative that can respond to anti-PD-1 directed approaches that can often relate to biomarkers we may not know about, or frankly, the biopsies taken from a site where the pertinent immunobiology is not taking place, for example, in a tumor-draining lymph node, which you may not have access to. And zooming in on an immunologic synapse, we have MHC1 and TCR. If you understand this slide, you understand all immunobiology in the sense that there's a lock and key so that when you activate a T cell, you don't activate every T cell in the body simultaneously. And so that's what the MHC1 complex with the TCR, that's signal 1 to lead to the initial activation. And then just like your automobile, we have an accelerator and a brake. And so we have TNF superreceptor family agonists here in green that actually accelerate the immune response. And in red, we have receptors that inhibit the immune response. And so these are druggable targets, and you see our friends CTLA4 and PD-1. And so these are antibodies that block a brake of the immune system and thus accelerate an immune response. And so it's a double negative from that standpoint. And so tumor mutational burden, and we may be hearing more about this biomarker relatively soon, is a way of looking at the number of keys that you have to look for cars in the parking lot. And so if you have, next slide, I think I'm frozen. Thank you. Forward. There we go. Oops. If you go back one more, please. And so if you look at tumor mutational burden by tumor type, these are the number of lottery tickets you have to have a specific antigen response against the tumor. And so we see that if you have UV-mediated damage on the far right with melanoma or smoking-related damage with lung cancer, bladder cancer, or small cell, you have a potential for high neoantigens. This increases the number of lotto tickets you have for your immune cells to fight the cancer. You may also notice that when you look at colorectal and uterine cancer, the y-axis, there's some there's some patients that have a higher mutational burden. Those are your microsatellite unstable patients who may respond to immune checkpoint blockade. And so what's interesting is tumor mutational burden and PD-L1 expression by IHC are orthogonal to each other, meaning they tell us different things about the immune system that generally don't overlap. And so if we look at some of the pivotal studies of nivolumab in the frontline setting, we see that there's about 15% of patients that had a high tumor mutational burden and high PD-L1 status, but there are patients who also had PD-L1 in the lower range and high tumor mutational burden, and patients who had high PD-L1 with lower tumor mutational burden. And so these are biomarkers that tell us different things about the cancer and the immunobiology, though to date, PD-L1 IHC remains the only validated biomarker to direct treatment decision-making in metastatic non-small cell lung cancer. And so we look at Checkmate 26 and the progression-free survival based on the cohort. This is an overall negative study. We see here in the nivolumab arm, an anti-PD-1 agent, that patients who are high TMB and high PD-L1 had the best survival, and that patients could respond even if their PD-L1 low, if they had a higher tumor mutational burden, or if their PD-L1 high with a low tumor mutational burden. And you see here that patients with lower tumor mutational burden, lower PD-L1 scores, tended not to have as robust a response. And we look at Checkmate 227, which is a study we're going to see some pivotal data from in the next 2 weeks at ESMO, which met its co-primary endpoint for improved overall survival with ipilimumab plus nivolumab in patients with greater than 1% PD-L1 expression. We see here that, in particular, patients with high tumor mutational burden, which represents the number of neoantigens that are potentially available for an immune response, there's substantial progression-free survival improvement of 43% in 1 year compared to 13% with chemotherapy alone, though the standard of care in the control arm has changed since the study has been underway, and now it represents chemoimmunotherapy, as Dr. West mentioned. And so tumor mutational burden in non-small cell lung cancer, the summary to date, and this very well may change in a couple weeks, is that there's an unclear clinical role for TMB given the lack of FDA-approved therapy for TMB-high patients. And there exist multiple issues with TMB that I won't have time to get into in terms of standardization across assays. As Sanjay mentioned, there's a blueprint to look at multiple PD-L1s. There's actually a blueprint for tumor mutational burden that's ongoing given the variety of assays that are currently used. What the appropriate cutoff is for tumor mutational burden. Some assays, it's greater than 20 mutations per megabase, other it's 10. Some have exome-based mutational profiling. Tissue input requirements, tissue versus cell-free DNA. There's been some really provocative data looking at blood tumor mutational burden. Depending on where you actually pick the tumor in terms of tumor heterogeneity, that can determine the tumor mutational burden as well. And finally, it's an expensive and a slower test than immunohistochemistry, which is often cheap and has a fast turnaround. Immunohistochemistry you can usually get back in 2 days. Next-generation sequencing can take 2 or 3 weeks. Although one of the features of next-generation sequencing is that for non-squamous patients, it forces clinicians to wait for driver mutation results before treating with anti-PD-1 therapy, which is a topic I'll get into momentarily. And so one point I wanted to discuss was microsatellite instability. And so microsatellite instability is actually a case of tumor mutational burden. It's a frame shift mutation, predominantly in gastrointestinal and gynecologic malignancies, endometrial cancer, gastric cancers, and so on. But it's usually not worth testing for in lung cancer for a couple reasons. You often have small biopsies, and you have to look for actionable driver mutations in EGFR, ALK, ROS1, and so on. And it wouldn't change management, whether it's non-small cell lung cancer or small cell lung cancer. And so I think clinicians often check this box when ordering next-generation sequencing in PD-L1. There's kind of an oculo-hand reflex to kind of just check all the boxes and be comprehensive. But I actually think doing mismatch repair testing in lung cancer burns through tissue that you otherwise need to answer more relevant questions. And so this is not something I would recommend. And so thinking about where we're headed, fundamentally tumor mutational burden looks at the number of lotto tickets you have for a pertinent immune response that you can unleash with anti-PD-1 blockade. But what if you could choose your own lotto ticket and pick the winning number beforehand? That would actually be the ideal scenario, and that's how you can game the system to win. And that's effectively what immunogenic neoantigen burden is. And so if the TMB represents the number of lotto tickets, you often only have one clonal neoantigen that's driving the immune response that's helping you chop down the cancer tree. And so rather than relying on just the odds of having 100 lotto tickets and hoping it lands, what if you actually picked your lotto ticket knowing what you think the winning number may be? And in fact, it's even more complicated than that. I showed you HLA typing and MHC. What if I actually let you pick 2 different types of tickets? And so that's what happens when you can present the neoantigen from multiple different aspects. And so fundamentally what this means is you see here, patients have a clonal neoantigen burden, the MTFR2. If you're able to get an immune response against that clonal neoantigen, you chop down the entirety of the cancer tree, and that's a very effective immune response. But you see in the patient next to them, MYADM2 and CHTF1, even if you try to get an effective neoantigen against that, you still have these large side branches, and you're not going to kill that tumor. And so the goal is, if you can actually identify this neoantigen, it becomes a perfect biomarker. It actually becomes a perfect therapy as well for a personalized neoantigen approach, and their clinical trials are looking at that. But fundamentally, you're looking for a single mutation. It's a needle in a haystack. And so with tumor mutational burden, you just have a lot of lotto tickets to look for that, while here, you can have a lower mutation burden if you know what you're actually looking for. And so is PD-L1 testing enough when we're talking about other facets, such as tumor mutational burden or immunogenic neoantigen burden? Yeah. And so this is probably the most important slide, because this is actually a real-world clinical problem. And what happens is we order PD-L1, and PD-L1 testing comes back in 2 days. It's an IHC. It's quick. And when you're seeing a patient who's sick, time is of the essence. But the molecular testing for EGFR, ALK, ROS1, and the other NCCN-recommended biomarkers for metastatic non-squamous non-small cell lung cancer often take 2 or 3 weeks to come back. So it's not like a board question or a slide that I show. These come back asynchronously. And one of the common mistakes we see is people will act on a PD-L1 greater than 50% for a patient with a driver mutation lung cancer. And part of it is the kinetics of the results coming back. And the other aspect is it's not completely understood that patients with greater than 50% PD-L1 scores actually may have a driver mutation. And so if you look here, almost half of patients with ROS1, RET, MET, other actionable aberrations for which we have pill-targeted therapies, that represents their best therapeutic option, actually have PD-L1 scores greater than 50%. So this is a total red herring. And the problem is, if you treat this patient with pembrolizumab, not only will it not work, there are actually no immune cells within the tumor microenvironment, but you increase the risk of toxicity from the targeted therapy once that next-generation sequencing comes back. And so absolutely it's key that please test for PD-L1, but please also wait for the other driver mutations that come back for a patient. And for patients who can't wait because they're very ill, you can give chemotherapy without the immunotherapy in order to best cool off the tumor and wait for the rest of the next generation sequencing to come back. And the reason is twofold. If you look here in green, the response rates are very low. KRAS may eventually be an actionable driver. But for MET, EGFR, HER2, ALK, ROS1, and RET, there are effectively no responses for PD-L1 high patients who are greater, and even if they're greater than 50%. And the second point is patients can have toxicity. In a study looking at patients who are PD-L1 high and EGFR mutated with pembrolizumab, this is before we knew the right approach, it was found, next slide, that 11 patients, it was stopped for utility, there was only one patient who responded, and they actually had their CLIA-CAP certification, and they looked back at those 11 patients, and actually turned out one of those patients didn't even have the EGFR mutation, so talk about a rough CLIA-CAP certification test. And then the other thing that happened is one of the patients actually died of pneumonitis, and so that's what we often see in patients who received immune checkpoint blockade with PD-1-directed therapy and then receive an EGFR-directed TKI, is they can get a potentially fatal pneumonitis. And so that's the reason it's important to wait for the driver mutations to return before acting. And if you can't wait, just to do chemotherapy by itself and wait to add the immunologic until you have that complete set of information. And so for patients with metastatic non-small cell lung cancer, it's important to make the right diagnosis, and that falls at least along 3 axes. One is the radiographic diagnosis with CNS and systemic head-to-toe imaging. 2 is the pathologic diagnosis and stage in which we direct a biopsy to the highest stage non-bone lesion, because bone lesions are often painful with less yield, and having more passes and more tissue is more helpful. And then the molecular diagnosis with either tissue-based multiplex testing or cell-free DNA, which is increasingly available. And PD-L1 IHC is helpful, but remember, it's a red herring, and even patients with driver mutations can have PD-L1 scores greater than 50%. Not only will they not respond to therapy if you give them an immunologic, but they may have a toxicity and potentially fatal toxicity with targeted therapy when you try to treat those patients later. And so TMB is an emerging biomarker for response to immune checkpoint blockade to anti-PD-L1 directed agents and potentially CTLA-4-based combinations. And while it seems to portend immunotherapeutic response, it's not ready for clinical use yet, though it may describe a patient population who's PD-L1 negative who may respond to immune checkpoint blockade. And that microsatellite instability testing or deficiency in mismatch repair should not be routinely tested for in lung cancer, whether it's non-small cell lung cancer or small cell lung cancer, due to the amount of tissue that it requires and the need to test for these other driver mutations. And the ability to predict immunogenic neoantigen burden, if you can actually pick the winning lotto ticket by having foreknowledge as opposed to just buying a lot of these lotto tickets in terms of TMB, represents a truly personalized biomarker to potential therapy for some of the personalized neoantigen vaccine studies that exist. And that in metastatic non-small cell lung cancer, we need to test for EGFR, ALK, ROS1, and the other NCCN biomarkers, even in PD-L1 positive patients, because as I showed you, it can be a red herring, and you can see a PD-L1 score greater than 50%, even for a patient with a driver mutation. And this can be a big issue if you start a patient because you get that PD-L1 IHC back in 2 days on pembrolizumab and you find out 2 weeks later they have an EGFR mutation. Starting that patient on osimertinib can be quite complicated in terms of their pneumonitis risk. And if a patient needs therapy right then and you can't wait for the next generation sequencing, think about doing chemotherapy alone and adding the pembrolizumab in cycle 2 while waiting for NGS, especially in your patients who have a limited smoking history. And so let's vote. And so which of the following biomarkers should not be routinely tested for in a patient with metastatic non-squamous non-small cell lung cancer and limited biopsy tissue? 1 ALK, 2 BRAF, 3 EGFR, 4 MSI, 5 NTRK fusions, 6 PD-L1, 7 ROS1, and 8 uncertain. Great. And so with that, I think, Jack, you'll be moderating the Q&A.
Right.
And I'd like to call Sanjay up.
Yeah. So we're at the end of time, but the next sessions don't start until 3, I think. So we have a couple of questions that came in, and I'd encourage people to ask questions if you'd like by using your, for folks who are online, you can do that. You can use your BlackBerry type pads, et cetera, and if you need to leave, do that. But a couple of questions have come in. One is for Sanjay. What are your thoughts on digital pathology for evaluating tumor biopsies? Do you see the medical community adopting this technology?
Yeah, this is a very broad question, a great question actually, because it's coming down the pike for all of us. Digital pathology for tumor biopsies. My personal opinion is that the ideal situation would be that digital pathology takes away our relatively menial tasks, counting. I don't like to count anything, but anything that needs counting, Ki67, counting mitoses, repetitive, the sort of labor-intensive tasks. I hope that digital pathology takes that away and leaves us with the more fulfilling, tasks, benign versus malignant, tumor subtyping. So that's my hope. Whether it will end up like that or not, I'm not sure, but that's my hope for digital pathology.
Another question is, if 22C3 is not used for PD-L1 testing, are there issues getting insurance approval for pembrolizumab? I would say that has not come up. One issue is that pembrolizumab is essentially an appropriate choice regardless. You can certainly, outside of doing it as monotherapy, it's never inappropriate, except for if you have a driver mutation. But Sandeep, I saw you nodding no, and that's been my experience. I've never had a patient get denied it because, for that matter, if it did come back as high but in a different assay, I just don't think that they're looking with that level of scrutiny. One other question I would ask, and Sandeep, I'd say that TMB, we got some less than positive results just at the Barcelona World Conference on Lung Cancer last week. Nothing definitive, but how optimistic are you that this is going to be a routinely used clinical tool in 2 years?
Yeah, I think it's a good question. The difference is a lot of studies we saw in Barcelona at World Lung were PD-1 directed studies. And so the question is, with the CTLA-4 based combination, would TMB be more informative? I think we'll have a lot more information in 2 weeks. My sense is if 227, the TMB analysis doesn't really drive decision making in terms of the PD-L1 greater than 1 or less than 1%, we'd be hard pressed to utilize that as a biomarker, especially in an era in which chemotherapy plus PD-1 seems to be the standard of care currently.
Okay. Well, I want to thank everyone for your participation, for your interest, for your voting. Thank also our sponsors for their support for this event, and for CCO, for Clinical Care Options, for putting this all together. Thanks, and enjoy the rest of the conference.